So we're back for the afternoon session. The idea for the afternoon is to, hey John, welcome back, is to discuss some video cases, to do another live case which may or may not have any bleeding, depending on the competencies of the endoscopist, and to really nail down the competency assessment tool. So I think because I want to use the competency assessment tool as a basis for everything, I've got a presentation where I've linked some videos to it, and then we have some cases, like proper cases. So I'll first start with that, I guess, which I think is this one. Yeah, okay. So we talked about the CAT before. There are two. I showed this before. So this is the Non-Variceal Upper GI Bleed CAT. We have already seen some demonstrations of field control. John has showed a video of inadequate field control during a heater probe procedure or a gold probe procedure. We have shown here a demonstration of how you can achieve field control, and actually John has showed multiple examples of how you can do it with irrigation, cap, whether or not you use RDI, tamponade, etc. And so we're going to go through it with some videos. So I'm going to go through the CAT in more detail than we did before and talk about what's good and what's bad. So I said we want to focus on this, but I do think for completeness we should discuss it. Glasgow-Batchford score. So at least you know what it is, and that you have at least used it to triage the patient. So if you don't know what is the Glasgow-Batchford, let's make this interactive. Mia, what is the Glasgow-Batchford score? I love demos, so I'm going to, in the meantime, use Google to find the Glasgow, because of course that's what you should do. You're on call, you should type Glasgow-Batchford score into Google, and hopefully it doesn't come up with anything that we don't want. MD Calc or any kind of thing. Here it is. So what is it? Yeah,
is a list of parameters of symptoms or not symptoms, but actual.
So it's good. It's not symptoms, right? It is actually something relatively objective, right? Which you can use to assess. And so it's hemoglobin, it's urea, it's initial systolic blood pressure, it's the sex of the patient, it's heart rate, it's melena, yes or no. This is maybe one of the least objective. Also recent syncope. Okay, this is also maybe objective and subjective. We all know as doctors that those can be used to get patients into hospital if you're a GP. No offense to you GPs, but this often happens in the UK. They say that the patient ends up in hospital. So you've got to be careful of those two. This one's relatively objective. This one's relatively objective. Yeah. And you get a score out of what? What's the maximum score?
12, I think.
Okay. Anyway, all right. So you get a maximum score, and based on that, you can get what?
First, what you need it is for understanding if a patient needs to be first admitted in the hospital or not. So if it's more than one, and then if it's you can decide if it's needed an endoscopy or not. And then of course, I mean, as we heard before from the presentation of Professor Manning, we heard that so in more than equal to 2 starts to have the higher probability of actually being possible bleeding. But as we said, as we have seen before, there are these cases where we have 2 or 3, and there is no at least in the first index endoscopy there is no source of bleeding, but it should be used to guide the choice of admission and endoscopy.
In 2 words, what should it be used for?
Triage.
Adam is mouthing them, please.
Risk stratification.
Risk stratification. So that is what we saw the hemopill, right, about. The hemopill presentation was